Whenever we're adopting a new therapy, we have to understand how that therapy actually presents an opportunity for the patient. Okay? Now clearly the objectives set out in a clinical trial, whilst they'll obviously attempt to reflect benefits which are important to patients, they also have to be measurable and deliverable within a clinical trial. So they're not always quite the same thing. Just because something works in a clinical trial doesn't necessarily mean that it suits the needs of patients, and certainly not the needs of every single patient. So by and large, what I do is I deliver drugs to patients which are not delivering a cure. Of course, that's what patients want, but we acknowledge during the consultation that the aim of treatment here is to control the disease. And of course, disease control means different things to different people, but fundamentally it's about trying to improve the symptoms the patient has now. It's about trying to delay new symptoms, and it's about trying to prolong survival. But of course, quality of life is always going to be a really important part of that equation. But the relative balance between quantity of life and quality of life, well, first of all, there's often a balance to be struck for the individual therapy, but the individual patient may have a different perspective on what's most important to them. And I guess what that means is, firstly, it's really important that we understand the quality of life impacts of our therapies. That can be positive, improving disease control, but of course it can be negative as well because of toxicities from treatments. Maybe about visits to hospitals, intravenous versus oral therapies, for example. And it's important that we attempt to measure those impacts in trials as well. And of course it also means that having a choice of treatments then becomes important, because if different patients have different expectations from treatment, then to be able to offer them a choice may help to get the treatment which best matches that individual patient's expectations. So if we want to talk about the data that were presented earlier this year at the ASCO GU meeting, looking at, I guess, not a new therapeutic area, but new therapies in an area which had not previously been successful in trials before. And this is in this concept of what we call M0 castration-resistant prostate cancer. So these are men who have prostate cancer. They have no known evidence of metastatic disease, which of course is the main source of morbidity and mortality in prostate cancer. But they've already been on primary androgen deprivation therapy and they are failing. And of course that failure in those men is measured by a rising PSA. So we know that there are two drugs, enzalutamide and apalutamide, both of which have been the subject of very similar clinical trials for these men who are not known to have metastatic disease and a rising PSA despite ongoing androgen deprivation therapy. Now, first of all, these trials are not in that whole group. This is in a group of patients who we know are at very high risk of developing metastatic disease, and that's defined by the rate at which the PSA is climbing, or the PSA doubling time, and for both of these trials that had to be less than 10 months. And of course the important thing with these patients is that by and large, because they have no metastatic disease, by and large they have very few, if any, symptoms from the disease itself. They may have some ongoing toxicities from the treatment they've been on, but by and large they are asymptomatic. Their quality of life is good. And so the important thing there is, by giving those patients drugs, it is unlikely I'm going to make them feel any better, because they're unlikely to have symptoms relating to the disease. However, we know that those patients are at very high risk of developing metastatic disease, and we know when they do, that's when the symptoms start to kick in, and we know that's the beginning of the period of the disease when the morbidity really starts to become problematic. So it's fundamentally important then that any treatment there can deliver those benefits in the future without causing unacceptable detriment in quality of life due to the negative impacts, the side effects of the drug. I guess these drugs are able to do that because the side effect profile is, we've been using enzalutamide for a long time in the treatment of men with more advanced forms of the disease, so we know that most men can tolerate that treatment very well. There are some who can't tolerate it, or it's not where it's unacceptable, but for most men it's entirely compatible with an ongoing normal quality of life. So I guess it's only really with the advent of these newer hormonal drugs where that low impact of side effects is compatible with this particular treatment domain.